It's a great honor to present Dr. Deuschl to give the Stanley Fahn Lecture on the enigma of action tremor in the elderly. Günther.
Presidents, ladies and gentlemen, dear colleagues, it's a great honor to give this Stan Fahn Lecture 2015. And if you want to guess how big this honor is, then you just have to look at the relief of my predecessor, which was Joe Jankovic, who gave the lecture last year. Stan, I just wanted to let you know from the very beginning that I will not go as far as Joe did last year, although you look really as amused as I've almost never seen you before. Okay, so let's go to the stuff. I have chosen this title because there are many controversies around essential tremor, but there is one which is really fundamental, and this is this one. There is no consensus so far if essential tremor at young and old age is a cumbersome but mostly benign disease, or if it's a progressive and possibly even life-limiting disease. This issue has a long history, and I will try to just introduce you to that kind of history and discuss a little bit the newer findings in this field. Let's start with this very much respected person. He wrote a paper in 1931 when he was still a junior neurologist at King's, saying that senile tremor constitutes the commonest instance of hypokinesis, although by no means often encountered. Its occurrence in the elderly has been noted from the earliest times by both laymen and physicians. It is indeed one of the traditional stamps of old age. All the others have mostly talked about senile tremor. He was the one who really pinpointed it, and he said senile tremor is, its common sites are head, lower jaw, hands and forearms. Today we would take it the other way around. The amplitude increases as soon as the limb is employed. There is a striking lack of disability. Fine manipulations of the fingers, however, soon become impaired. And already in these days, he said, possibly senile tremor represents a delayed form of the idiopathic family tremor, suggesting that the frontier between essential and the senile form is ill-defined. Well, we could say the same thing today. There's no change. Well, in these days, there were two positions held. One was held by this person, Professor Meiner, who was a Russian neurologist coming from Latvia. And he came to the conclusion that essential tremor has something like a status macrobioticus multiparus, which means that it's a condition characterized by tremor, longevity, and fertility. So for him, it was an advantage to have an essential tremor. And in 1949, Critchley summarized the situation as it was standing in these days. In the literature, there are accordingly two contrary viewpoints, namely that essential tremor is a sort of macrobiotic manifestation, and conversely that it is a degenerative disorder associated with the neuropathic family taint. Despite the size of the literature, there is still an inadequate documentation. True until today. Just a remark. Degenerative in these days meant something different than today. In these days, it meant that it's not only this symptom, but it has also other neuropsychiatric connotations. Other neuropsychiatric conditions occur with it. So this is the long-standing controversy about which we are talking. We have tremor as a sign of aging, and ET comes with neurodegeneration that has been put forward in the 19th century already, and then later in the 20th century. And just now, there is a revival of this hypothesis. And on the other hand, there was a group of researchers and clinicians which believe that ET comes with unaffected or even longer life expectancy with mostly limited morbidity. And that has been put forward by Pellner. That's the first one where I found this like this. Joe Jankovic has written a paper in '95, which I would like to particularly mention. He has done a study in these days, which is probably not really, is not compatible with modern methods, but he just looked at the age at death of the parents of patients with essential tremor and compared that to a control group. And thereby he found that the parents of patients with essential tremor were on average 8 years older. Okay, modern findings in favor of neurodegeneration. Pathology is certainly the first point that comes to your mind when it comes to neurodegeneration. There have been 19 cases since the 30s, and in 2004, the knowledge about the neuropathology of essential tremor was just doubled. But all these 40 cases found inconsistent pathology. And it was not until Elan Lewis published a number of papers, and overall he claimed that there are two types of pathology. One is ET with Lewy bodies, another is ET without Lewy bodies, but they have a Purkinje cell loss and torpedoes. Holy Schill had 24 patients, that's the group in Arizona, and they found inconsistent pathology and could not confirm the findings of Elan. And then there was Alex Rajput, another group that is doing this kind of research since decades. And they found that Purkinje cell loss is age-dependent and not specific for ET. So that's where the situation stands, and the Movement Disorder Society and also the NIH are very much interested in this, and we recently had a meeting and we agreed that these three groups have to go together and sort this out, whether there's pathology or not. But I wanted to put forward an idea which I simply cannot throw away. After 50 years of a disease, people die mostly from other reasons. And then neuropathologists look at these brains, and then they have problems to see the same features. This is just difficult to understand for a simple clinician. Really, the evidence in favor of pathological neurodegeneration is probably quite limited. Can genetics identify a genetic abnormality related to neurodegeneration? Well, there are, as you know, 3 loci in linkage studies, but no gene has been found so far. There are 2 risk genes in GWAS studies that show up, but and they may be related to neurodegeneration, but as you know, it's a very borderline finding. And there's one family with a FUS gene mutation. And the FUS gene, as you know, is involved in ALS, so that's a definite probable hint towards a neurodegenerative process. But this genetic finding has not been confirmed in other cohorts. So the best evidence for neurodegeneration, in my view, is the clinical evidence, and that's epidemiological evidence. There are 2 large epidemiological studies in New York and in Spain, and prevalent dementia is increased in ET in the New York study. This is also true for the Spanish study, but there it's only for those cases above older than 65 years. And also incident dementia is increased in ET with onset beyond 65 years. But keep in mind, there is, and there's even a higher mortality in ET, but keep in mind that there is still the Joe's finding from 1995. So the question is, can age at onset help to discriminate subgroups of tremors? Well, if you look at the prevalence of essential tremor, then you see that starting from the age of 40, the 5th decade, the prevalence is increasing very much until almost 10% in subjects in cohorts with an age above 90. We have looked at this issue in more detail with the Danish twin registry in Odense, which is relatively close to Kiel. This was already in 2001, and in these days they had 2,327 subjects in the study. They were all older than 70 years. They were all single twins or intact twin pairs. The subjects were assessed in 2001 with a very extended interview and some aging tests, so hand grip, neuropsychological standard tests, activities of daily living, medication, and morbidity. Tremor was assessed with the Archimedes spiral. This group has special features. First of all, the old age at inclusion, older than 70 years. We have a long observation period between 2001 and 2014. Most of the patients are already dead in 2014, and hence the event rate of mortality is very high. It is a unique cohort because we have the connection between this cohort and national databases of Denmark, mortality data, healthcare system data. That's all possible in Denmark, and therefore the databases there are so important. But we have a limitation. The personal assessment was only done in a subgroup of 12%. But even that, Delia was doing that in 2002, and even that took 9 months for her. Well, this is a very important contribution of Stan. He wrote the most important tremor rating scale in '93, and he published it with Conchita Marin and with this particular person here. You see also the other, so maybe that was around that time, and maybe they were just celebrating a paper in these days. You see here Stan, and you see here David in a very characteristic position. We all know this from these days, and it's one of the highly cited of your papers, Stan, actually 584 quotations. But we didn't have this in all these 2,300 patients. We looked at tremor severity by looking at spirals. And this procedure is used by many groups, and it has shown validity, test, retest, reliability, and it is a very good test. And we have data of this test comparing that with the Fahn score. The Fahn score is a personal assessment, as I said. And when you look at the relation between the tremor severity according to the Bain score and the Fahn score, you get this. So this is almost a perfect logarithmic relation between them, and therefore we believe that we do have a surrogate parameter with these tremor score for tremor. And that enables us to look into the data from this particular cohort. Oh no, before I go into the details, I have to mention another point. The question is, what is an abnormal spiral? If you look here, where does tremor really begin? Is it here or is it there? So we have made the following decision. We have just said grade 3 means that most of the spirals are with a rhythmic activity, as you can see here, but there are some which do not have clear rhythmic activity, while at grade 4 all of them do have it, and that's how we rate them. So grade 4 is, in our view, a manifest tremor, while grade 3 is borderline. So how do the spiral score distribute in this population? Well, we have about a quarter that has a pathologic tremor, that has a symptomatic tremor. The others have less intense tremor severity, 3, or they have no tremor. And this enables just to compare how these people here, how they differ with respect to some aspects that we have in the database. First of all, how is the mean spiral score in the different age groups? And what you can see is that the different age groups, there's a clear increase between 70 and 90. You can look at the prevalence of symptomatic tremors in subjects with an age above 70, those which have a spiral score of 4 and greater. And you see that this is true for 20% of the patients, of the subjects that are not patients, between 70 and 74, and it's almost 90%, almost 50% in those above 90. So it's a very frequent condition. And then we can look at the hazard ratio for mortality. And that is also heavily increasing with age, meaning that when you compare it with the reference population, which is 0 to 2 spiral score, then at a spiral score of 5 to 7, you have a hazard ratio of 1.84, which means that the likelihood to die at any age between 70 and 90 is 84% higher than the control population. This is probably the most important slide of my presentation because it clearly shows that the survival curves are depending on the spiral core, on the tremor severity as shown here. So this is no tremor, this is tremor 3, this is 4, and this is 5 to 7. How can we measure aging? So far we have measured tremor and we have measured mortality, but we want to know if tremor is also related to aging and not only to mortality. Well, you can look at epidemiologically established aging parameters. One of them is grip strength. Just to note, aging does not begin at the age of 60 or so. It begins pretty early, ladies and gentlemen. So even at 35, your grip strength is decreasing. Also, your cognitive composite and mobility score is decreasing. These are very strong data from large groups that have been investigated with these parameters. And now we can use these parameters to look at our tremor group. And this is what I'm going to do in a second. So, what did we find? Well, we found that grip strength, for example, is decreased depending on the tremor score. So 75 kilopond less, 0.9 kilopond less for tremor severity 4, and for the group 5 to 7, it's almost 3 kilopond less than the control population. The same applies for the cognitive composite and for the ADL score. If we know that it is related to aging parameters, if that tremor is related to aging parameters, then we certainly want to know, is it explained by these aging parameters? And we have to look for the hazard ratio, but we have to control for all these parameters. And what you can see is when you control for age, sex, medication, grip strength, ADL, and cognitive functioning, there is still a significant hazard ratio of 1.25, meaning that the likelihood to die is 25% higher for a tremor subject, which is spiral core 4 or above. So to get this very clear until here, tremor in the elderly is a risk factor for mortality that is strongly related to aging parameters. Even when we control for classical aging factors, the mortality risk of tremor is increased by 25% at any age above 70. That's the conclusion from this study. Tremor is therefore not an innocent bystander of bad health. It has its own effect on mortality, and it is a new risk factor for mortality. And, just clinically speaking, late onset tremor is a senile tremor. Senile tremor is probably politically no longer correct, and therefore we propose to name this aging-related tremor. What about classical essential tremor? Does it fit with these features? Well, we have these 276 subjects which Delia has visited, and 36 of them were definite ET, 69 probable ET, and we can look certainly at the parameters that we have looked in the larger cohort. And what you see here is that the definite ETs are not, do not have a similarly increased hazard ratio for mortality. the hazard ratio is lowered. It is lower. And it's also lower for the possible and probable ETs, while it's the same for the other tremors as for the senile tremors and for the age-related tremors. But as you can see here, findings are not significant, and therefore they are not much of a value. But there are significant findings regarding the aging parameters. They are not worse than the control population. They are better. So they have a stronger grip strength, they have a better cognitive score, and they have a higher ADL score, and that is significant here. So this part of our study is clearly underpowered, but so far there's no evidence that mortality is increased in classical early onset ET. So probably these two conditions differ. So we asked ourselves if we can separate early onset from aging-related tremor clinically, certainly a very obvious question. We looked at the ET cohort in Kiel, and we found almost 1,000 patients with definite or probable ET that we have collected over the past 15 years. And these people were all involved in this study. The age at onset in the Kiel cohort is, you have here a peak at young age and a peak at old age, so we just can dichotomize the group and can look at those, at the clinical differences of early and of late onset tremors. And what you see, first of all, male-female ratio is the same in both conditions. Men are more often suffering from ET, from tremor than female. The tremor severity is not significantly different in the two groups. The topography in the two groups is not significantly different, but certainly the mean age and onsets and the disease duration just by definition. Are there further clinical differences? Yes, there are. Alcohol responsiveness is higher in the early onset group, and family history is higher in the early onset group. And the tremor progression is faster, much faster in the late onset tremor group. But all these features don't allow you to say, when you have a particular patient, this is an ET patient or an ART patient. So there is no clinical way to look at this. We have been looking at electrophysiological differences between early onset and late onset tremor. And just what kind of electrophysiological differences? Well, there's a tremor network, as many of you know. There are places in the brain that are activated related to peripheral tremor. And the way you look at this is that you put patients either in an MEG or high-density EEG, or even in an MRI scanner, and then you look at the related activity in the brain to the peripheral tremor. And then you find these activations, these cortical activations in the primary motor cortex and the frontal cortex, mostly in the thalamus and in the contralateral cerebellum. This has been nicely shown for Parkinson tremor. It has been shown for Wilson's tremor. For essential tremor, here you have an additional source in the brainstem in all of them, and we have shown this also for orthostatic tremor. And you see that sometimes you have a very precise location of this activation. We have been comparing early onset and late onset tremor in two groups of patients. These were the people who were involved in this study. We have used high-density EEG, and tremor was used as tremor activity was used as the reference. And here you see the two groups, which by itself is quite interesting. These were just groups, just patients that we could get hold of, which fulfilled either the criterion of early or late onset, and which were matched for age. And you see that in this group, certainly age at onset differs very much, and disease duration just by definition. The tremor severity is the same, and also the distribution is the same, but already in this small group you see a difference of muscle strength, and you see a difference of the composite score in these 10 versus 10 patients. So probably in the future we will diagnose ART by making neuropsychological tests. The pattern that we found with this kind of assessment was the classical pattern of ET. You can see this here. Motor cortex, prefrontal cortex, thalamus, cerebellum, and brainstem were all activated, and we can also look at the directed coherence. This goes too far at this moment, and it's not necessary, but it was like we know it from many other cases with essential tremor, and this is the pattern of aging-related tremor. So we don't have a source in the brainstem and in the cerebellum in this particular group. And we did a second group, certainly, and again, we didn't find it. It was controlled for all the parameters, tremor severity and EMG amplitude and whatever. We couldn't find a source below the thalamus. So that may be in the future another way to look at it, because under these circumstances you have to consider other ways how this tremor is caused, and we may want to look at this. So this is the situation. You have a corticothalamic origin of this aging-related tremor, while it is different for the classical early onset ET. So let me summarize. We have found that late onset tremor is increasing with age and aging parameters, but a separate risk factor for mortality. So we propose to call this an aging-related tremor. Motor features of ART are indistinguishable from early onset ET, but aging parameters like cognition and grip force may help. Perhaps we have to diagnose this subgroup in the future just by looking at cognition, by measuring grip force and having a reassessment after 2 years. The underlying tremor network seems to differ for these two tremor forms. And finally, early onset ET and ART are probably different conditions. And if that is the case, we would have solved the enigma of action tremor in the elderly, because then we have the ART as one form of tremor and the early onset essential tremor as the other. Thank you very much.